Hello, welcome to Systemic Embryology. Today's topic is development of body cavities and diaphragm. So, systemic embryology, we would begin with this topic today. So, to understand body cavities development, it is important to understand intraembryonic mesoderm and intraembryonic coelom development. So, here is the image demonstrating the intraembryonic mesoderm and coelom as well. So, intraembryonic coelom is the cavity which becomes prominent during 4th week during the folding of the embryo. So, the cavity appears within the lateral plate mesoderm. So, if you know the intraembryonic mesoderm, it is divided into 3 parts. The medial most is the paraxial mesoderm, which forms the somites having dermatome, myotome, sclerotome, and in between is the intermediate mesoderm, which is a narrow strip of mesoderm which forms urogenital system. So lastly, the lateral plate mesoderm. The lateral plate mesoderm is further divided into the part which is along the ectoderm forms the somatopleuric, and the part along with the endoderm forms the splanchno-pleuric lateral plate mesoderm. And the cavity which protrudes into these, separating these two layers, is the intraembryonic coelom. And this intraembryonic coelom, initially it forms like large small cavities, and which all fuse to form a horseshoe shaped coelom. So the cavity appears in the lateral plate of intraembryonic mesoderm, dividing into dorsal somatopleuric mesoderm and ventral splanchno-pleuric mesoderm. So the ventral splanchno-pleuric mesoderm lines the yolk sac, and dorsal somatopleuric mesoderm lines the amniotic cavity. So somatopleuric layer is related to the ectoderm, and splanchno-pleuric layer is related to endoderm. So in the 4th week, the intraembryonic coelom, if you see, it takes a horseshoe shaped coelom. It takes like an horseshoe shaped coelom. It assumes like that. And the intraembryonic coelom, it provides the space actually for the organs to develop, and also not only it provides the space for the organs to develop, but also it helps in the movement of the organs within the cavity. Formation of intraembryonic coelom begins with the small spaces, the spaces which coalesce with the lateral plate lateral mesoderm and forms a horseshoe shaped space, and that opens into the chorionic intraembryonic coelom, and it remodeled due to craniocaudal foldings. So here we can see the lateral foldings of the embryo on each side. So because of the lateral foldings, the intraembryonic coelom will start incorporating, extending inside, and in the next image I will show about the craniocaudal folding as well. So because of these folds, the coelom becomes like a balloon like, whose walls are closest at the body wall, that is the somatic mesoderm. So now let us understand the division of this intraembryonic coelom. So intraembryonic coelom, because of this is the head fold within the embryo and tail fold. Initially it is a large space, it is a continuous space, but later because of the gradual development of these folds of the embryo and also the partitioning membranes, the membranes will form separating the cavities into 3 cavities: pericardial cavity, pleural cavity and peritoneal cavities. So these cavities are seen during 4th week of development. So initially it is a continuous space, but gradually develop partitioning to form a definitive adult pericardial, pleural and peritoneal cavities. So the two partitions which develop are the paired pleuro-pericardial membranes. So we can see the pleuro-pericardial membranes which separates the membranes of the and the diaphragm. The diaphragm separates the thoracic cavity from abdominal cavity. So it separates the pleural and pericardial cavities from the peritoneal cavity. And the pleuro-pericardial membrane which separates the pleural cavity from the pericardial cavity. So this is the basic thing to be understood. So we can see the pericardio-peritoneal canals here. This is the septum transversum. This is the septum transversum. Initially it is at the cranial end. We can see the pericardial cavity developing with the septum transversum. Septum transversum forms the fibrous pericardium, and pericardial cavity forms the visceral, that is the visceral layer, and the parietal layer of serous pericardium. And this pericardio-peritoneal canals which communicates with the pericardial to the peritoneum. So this is the basic idea. And here in horizontal section we can see the pericardial cavity. This is the developing heart tube, and we can see the lung buds grow into pericardio-peritoneal canals, forming into pleural cavity later. So we can see the primitive esophagus. This is the tracheal part of the laryngotracheal diverticulum which forms the lung buds. Later the lung buds grow into this pericardio-peritoneal canals which later form into pleural cavity. This forms the pericardial cavity. So the paired pleuro-pericardial membranes, they are like sheaths. They are like sheaths, these pericardio-peritoneal, pleuro-pericardial membranes. And these sheaths of somatic mesoderm separates the pericardial cavity from the pleural cavity. So this is the pericardial cavity, and this would form the pleural cavity. This sheath is called, this one separation partition between them is called as pleuro-pericardial membrane. And these cavities, if you see, it is lined by the parietal mesothelium derived from somatopleuric mesoderm, and visceral mesothelium which is derived from splanchno-pleuric mesoderm. So their formation is aided by the lung buds invading into the lateral body wall and by the tension of common cardinal veins resulting from rapid longitudinal growth. And these membranes develop into a definite fibrous pericardium which surrounds the heart. So we can see the septum transversum contributes the formation of pericardium, forming fibrous pericardium of the heart. So this is a basic idea. So let us understand in this image. This is the head fold of the embryo, this is the tail fold of the embryo, and we can see the amniotic cavity, the blue one, and we can see this is the heart, developing heart, pericardial cavity. This is the heart tube, the red one is the heart tube. So this is the pericardial cavity, and this is pericardio-peritoneal canal, and this forms the peritoneal cavity. So the pericardial cavity, the cranial part of the cavity which bends ventrally due to the head fold of the embryo, it narrows the central part. So because of this fold, this part will get narrowed down and lies cranial to the midline behind the septum transversum. So here is the septum transversum, growing septum transversum. This is the heart tube. This is the heart tube, developing heart tube. These are the two dorsal aortae. And this is the yellow one is the foregut. So from the foregut we see the development of lung buds from laryngotracheal groove which is present in the floor of the pharynx, the caudal part of the floor of the pharynx. We see the development of laryngotracheal groove which grows into this the lung buds which grows into this pericardio pleural cavities. So after folding, the pericardial cavity lies ventrally and the two pericardio-peritoneal canals pass on the either side. This is the pericardio-peritoneal canals. They pass on the either side which communicates with the caudal part of the cavity called as peritoneal cavity. The two lung buds arising from the foregut invaginate into pericardio-peritoneal canals. So the lung buds will invaginate into this pericardio-peritoneal canals, turning these canals into pleural cavities. So with the growth of the enlargement of the lung buds, these canals also expand and form pleural cavities in later on life. So the lateral extensions of the pericardial cavity from future pleural and peritoneal cavities. So the distal end of these lateral extension continues with the extraembryonic coelom. So the distal end they continues with the extraembryonic coelom, and these communications are seen at the lateral edges of the embryonic disc. And these communications are important because the midgut herniates through this communication at the umbilicus, and this is temporary communication, and it is lost during 10th week after complete involution of midgut loops into the peritoneal cavity. So during the folding of the embryo, the lateral folds, they approximate with each other. So here you are seeing head fold and tail fold. On each side will be the lateral fold, they will approximate with each other on the ventral aspect of the embryo, and at the site of approximation meeting point, the ventral mesentery will form that disappears, resulting a large body cavity which is called as peritoneal cavity, which extends from the cardiac area to the pelvic area. So this large cavity will be the peritoneal cavity. Next is about the pericardio-peritoneal canal, this one, which I already said, as which is a communication between the pericardial cavity and peritoneal cavity. These canals later forms pleural cavity. And as the pericardial cavity is relocated ventrally anterior to the foregut, as a result the pericardial cavity opens into the pericardio-peritoneal canals, which are dorsal to the foregut. So here you can see, so they are present dorsal to the foregut. Ventrally is the foregut, which are present on the either side of the foregut, into which the lung buds will develop. So this is a basic idea how the intraembryonic coelom, how it is splitting into these cavities. So next about the dorsal mesentery in the peritoneal cavity. I already talked about the ventral mesentery, which disappears completely, establishing a horseshoe shaped cavity in transverse section. So the dorsal mesentery is developed like seen after the completion of folding of the lower part of the foregut. Midgut and hindgut are suspended from the dorsal body wall by dorsal mesentery. So mesentery is a double layered peritoneum and covers the visceral organs and connects to the posterior abdominal wall, and it conveys neurovascular bundle. So the nerves and blood vessels supplying the gut, they are conveyed through this dorsal mesentery. And both the dorsal and the ventral mesenteries divide the peritoneal cavity into right and left halves initially, and eventually we know that the ventral mesentery disappear except near the caudal part of the foregut, which is the future stomach. It forms the part of lesser sac, and where it is continuous with the rest of the peritoneal cavity, which is called as greater sac. The communication is called as epiploic foramen. The communication between the lesser and the greater sac is called as epiploic foramen. So blood vessels traverses through the layers of the dorsal mesentery to reach the gut. So this is a basic idea about the dorsal mesentery and ventral mesentery as well. So next we shall understand about this septum transversum. So septum transversum is the aggregation of mesenchymal tissue derived from the mesoderm. So the intraembryonic mesoderm, which is cranial to the procaudal plate, will form the septum transversum. So the septum transversum is a thick plate of mesodermal tissue that occupies between the thoracic and abdominal cavities later on. So initially if you see the septum transversum, it is present near the cranial end of the embryo, and because of the head fold, the septum transversum comes to lie on the ventral side of the embryo. So, ventral side near the cardiogenic area it will form. So, initially it lies cranially, cranial to the heart, but later due to the head fold of the embryo it is repositioned between the heart and the connecting stalk. So, you can see here this is the septum transversum, this is the connecting stalk, and here is the developing heart, and also the respiratory lung buds are seen here. The liver develops within the septum transversum. So, you can see the septum transversum where the liver is developing inside it, and it forms a part of diaphragm, it forms a connective tissue of the liver, and it forms the fibrous pericardium of the heart. So, these are the derivatives of septum transversum. So, initially it is on the cranial side. Because of this head fold, it moves towards the ventral side of the embryo. So, it forms the central tendon of diaphragm, which is like a partial partition between thoracic and abdominal cavity, and this partition forms in each pericardio-peritoneal canals, separating the pericardial cavity from pleural cavity. And along the lateral wall of the pleuro-pericardial canal, the membranous ridges appear, a pair of superior and a pair of inferior membranous ridges they appear, and because of the growth of the lung buds, the superior ridges are pleuro-peritoneal folds located below the developing lungs. So, this is how the cavities form and the septum transversum forms. So, let us see how the septum transversum forms the partition. So, pleuro-pericardial membrane, how it forms along with the septum transversum. So, the partition of the intra-embryonic coelom to form a definitive pericardial, pleural and peritoneal cavities from a single intraembryonic coelom. So, three partitions will develop. These are paired pleuro-pericardial membranes. There are two. I have written one. There are actually two. And diaphragm is one partition. So, these three partitions together forms these cavities. So, pleuro-pericardial membrane we will see now. So, the lung buds grow into the pleuro-pericardial canals. So, here these are the pericardio-peritoneal canals. Okay, and this is the septum transversum developing, and we can see the developing lung bud from the foregut. So, this is the developing lung bud from the foregut. So, the lung bud grows laterally, protruding into this pleuro-pericardial canals, pleuro-peritoneal canals, which later forms pleural cavity. So, pleuro-pericardial membranes, that is the lung buds, grow into this pleuro-pericardial canals, which are the future pleural cavities. And as the pleural cavities expand around the developing heart, splitting the mesenchyme into the outer layer, which forms the thoracic wall, and inner pleuro-pericardial membrane that forms the fibrous pericardium, and also covering pericardial sac enclosing the heart. And the pleuro-pericardial membranes forms the partition between the pericardial and pleural cavity. And each pleuro-pericardial canal lies lateral to the primitive esophagus. So, here we can see the primitive esophagus, each pleuro-pericardial canal is present on each side, peritoneal canal which is present on each side of the primitive esophagus, dorsal to the septum transversum. This is the septum transversum which is on the ventral side, and these canals are present on each side dorsally, and this is the dorsal mesentery which is connecting the developing gut to the posterior abdominal wall. And so these are filled with the membranes which are called as pleuro-pericardial membranes. So each pleuro-pericardial canal lies lateral to the primitive gut, dorsal to the septum transversum, and these partitions contain common cardinal veins that which drain from the body wall of the embryo into sinus venosus, that is the venous end of the heart tube, and the lateral pleuro-peritoneal folds grow to form membranes, and they are concentric free edges projects into the caudal ends of the pericardio-peritoneal canals. These canals that separate the pericardial cavity from the peritoneal cavity. So these canals, pericardio-peritoneal canals, this separates the pericardial cavity from the peritoneal cavity. During 6th week, these membranes will form. You can see the pleuro-pericardial membrane, they form during 6th week. With the from the dorsal, this is the dorsal mesentery. So with the dorsal mesentery of the esophagus and the septum transversum to form a part of diaphragm, it fills to form a part of diaphragm. So with the growth of the lung bud into the pericardio-peritoneal canals, a pair of membranous ridges are produced in the lateral wall of this canal. So these are cranial ridge called as pleuro-pericardial fold, which is present above the lung, developing lung bud, and caudal ridge is called as pleuro-peritoneal fold, which is present below the lung bud. So pleuro-pericardial fold separates the pericardial cavity from the pleural cavities as they enlarge, and gradually folds becomes membranous and forms pleuro-pericardial membrane. As the pleuro-peritoneal fold, which is a lower fold, it also enlarges and it projects into the pericardio-peritoneal canal, and gradually the fold becomes membranous and forms pleuro-peritoneal membrane, which forms a part of diaphragm and which approximates with this septum transversum, closing this communication. So let's see the formation of diaphragm. This is very important. Diaphragm, we know it is a musculo-tendinous partition, separates the thoracic cavity from the abdominal cavity. So diaphragm develops from septum transversum. This is the ventral side septum transversum. So septum transversum forms the muscular component which is derived from the cervical myotomes. So this septum transversum, initially it is present in the cranial end of the embryo at the cervical level, that is from C3 to C5, and later it moves ventrally. It shifts ventrally because of the head fold of embryo. And other sources which forms the diaphragm are pleuro-peritoneal membranes. This is pleuro-peritoneal membranes, and the other one is pericardio-peritoneal membranes and dorsal mesentery. Pleuro-peritoneal, pericardio-peritoneal membranes will shift upper. So this is pleuro-peritoneal membrane and dorsal mesentery. Dorsal mesentery of what? Of esophagus. So the muscular growth of the lateral body walls on each side, this red one, formed from the lateral body walls, join with the septum transversum to form a complete diaphragm. So starting with the septum transversum again, it is opposite to cervical somites during 4th week of development, and these are supplied by cervical nerves C3, C4, C5, which gives rise to phrenic nerve. So the root value of phrenic nerve is C3, C4, C5 because the septum transversum is developed in the cervical myotomes. And muscular component of the cervical myotomes somites give from C3, C4, C5 forms the septum transversum. This explains that the diaphragm is innervated by phrenic nerve, and it is through fibrous pericardium from which pleuro-pericardial folds form. Then the septum transversum forms the central tendon of the diaphragm, which is not enough to separate the thoracic cavity from abdominal cavity. So this part is still empty, and peripherally also it is still gap is there. So to fill the gap, what are the additional features are the abdominal pericardio-peritoneal canals are present on each side. So the large part of the liver bud is embedded in the septum transversum, which forms the connective tissue of the liver, and pleuro-peritoneal membranes. These are the pleuro-peritoneal membranes, which these membranes fuses with the septum transversum and the dorsal mesentery to form a primitive diaphragm. Then pleuro-peritoneal membranes develop and close the pleuro-peritoneal canals, and they fuse with the dorsal mesentery to form dorsal mesentery of the esophagus and the septum transversum. Dorsal mesentery of the esophagus, it forms a little part of diaphragm, and this mesentery fuses with the septum transversum and pleuro-peritoneal folds. You can see this white one is the dorsal mesentery of esophagus, and the dorsal mesentery of it forms the dorsal mesentery of diaphragm, which is invaded by myoblast later and form the crura of the diaphragm, where it gives the origin to the diaphragm. It makes the crura of the diaphragm in adults from the myoblast of dorsal mesentery. During 9th to 12th week, due to the growth of the lung buds and its pleural cavities in the lateral wall, on each side developing pleural cavity, that is the pleuro-peritoneal canal, burrows into the lateral body wall, and further the lateral splits into two layers, that is the external and the internal layer, and external layer will form a definitive body wall, and internal layer forms the peripheral parts of the diaphragm. So peripheral parts of the diaphragm, which are derived from the pleuro-peritoneal membranes, parts of pleuro-peritoneal membranes and lateral body wall. So this completes the development of diaphragm. So summary. See, septum transversum forms the central tendon of diaphragm. Pleuro-peritoneal membranes forms the small peripheral part of diaphragm. Dorsal mesentery forms the crura of diaphragm. Mesoderm of the body wall forms the lateral outer peripheral parts of the diaphragm, external to the parts derived from the pleuro-peritoneal membrane. So the nerve supply of diaphragm, at first it is during the 4th week of gestation. Septum transversum lies at the cervical region opposite to C3, C4, C5 cervical somites and supplied by corresponding cervical spinal segments C3, C4, C5. The phrenic nerve root value, that is the reason C3, C4, C5 reaches the diaphragm through pleuro-pericardial folds, which forms the fibrous pericardium. So later during the 6th week of intrauterine life, the diaphragm descends caudally to its definitive position, that is the thoraco-abdominal junction opposite to T7 to T12 spinal segments. So the descent of diaphragm occurs due to the elongation of neck, descent of heart and expansion of pleural cavities. So when the diaphragm descends, it carries its nerve supply with it. So hence the diaphragm is supplied by phrenic nerve. So since the peripheral parts of the diaphragm develop from the lateral body wall, it also receives sensory innervation from lower intercostal nerves. So this is the summary all about the development of diaphragm, embryonic structures and adult derivatives. Position of septum transversum, I already said same thing. So let us talk about some clinical correlations associated with the development of diaphragm. Congenital diaphragmatic hernia. Malformation of the diaphragm allows the abdominal organs to push into the thoracic cavity or chest cavity, hindering proper lung formation. So congenital diaphragm hernia is a birth defect of the diaphragm. Most common type of congenital diaphragmatic hernia is Bagdolot's hernia, where And the next congenital hernia is foramen magnum, foramen morgagni, hernia through foramen morgagni, that is called as Morgagni hernia. And third type is diaphragmatic eventration, where the central tendon defects of the diaphragm, or the other types of congenital hernias you will be seen. So first we shall discuss about the Bagdolex hernia. It is also known as posterolateral diaphragmatic hernia. So this is anterior side, this is the posterior side. So pleuroperitoneal folds are not formed properly, resulting in Bagdolex hernia, which is a posterolateral hernia, characterized by a hole in the posterolateral corner of the diaphragm, which allows the passage of abdominal viscera into the chest cavity. So the majority of Bagdolex hernia occurs in the left side of the diaphragm. So common site is left side of diaphragm. Next is the Morgagni hernia. This is the opening Morgagni hernia. It is a rare anterior defect of the diaphragm. This is the anterior defect. This is posterolateral defect. Remember it. And it is usually retrosternal, behind the sternum, or parasternal. So the hernia is Morgagni, retrosternal or parasternal hernia. It is characterized by the herniation through the foramen of Morgagni, which are located immediately adjacent or posterior to the xiphoid process of sternum. Next about the diaphragmatic eventration. So diaphragmatic eventration, it is a congenital diaphragmatic eventration, means abnormal displacement or elevation. In this condition you can see here, this is abnormally elevated on one side. So the musculature of one half of the diaphragm remains thin and membranous, and hence it balloons out into the thorax, forming a diaphragmatic pouch, and because of the upward displacement of the abdominal viscera. And this anomaly occurs when the muscular tissue does not develop in the pleuro-pericardial membrane. It is more common on the left side, just like Bagdolex, it is more common on the left side. And this occurs because in the region of eventration of diaphragm is thinner, allowing the abdominal viscera to protrude upwards, resulting abnormal elevation. Next condition is esophageal hiatal hernia. So you can see the the esophagus opening, that is herniation through the esophagus opening. So herniation is of the upper part of the stomach through the esophageal hiatus into the chest cavity or the pleural cavity, caused by the abnormally large esophageal hiatus. And an esophageal hiatal hernia renders esophagogastric reflex. It is called esophagogastric sphincter is incompetent, so that the stomach contents reflex into the esophagus. So clinical signs of the newborn include vomiting and frequently projectile vomiting when the infant is laid on back after feeding. So that is the symptom for esophageal hiatal hernia. So that was about the body cavities and the development of diaphragm. So let us see some questions associated with this topic. So diaphragm does not develop from body wall, pleuroperitoneal membrane, pleuropericardial membrane, septum transversum. I hope you know the answer. It pleuropericardial membrane forms the upper part above the separating the pericardial cavity from pleural cavity. It is nothing to do with the diaphragm. So that is the reason the answer is pleuropericardial membrane. So diaphragm does not have contribution from pleuropericardial membrane, which is a sheet of somatic mesoderm that separates the pericardial cavity from the pleural cavity and forms the fibrous pericardium surrounding the heart. Next, about most common site of Morgagni hernia is, I hope you know this answer, left anterior, right posterior, right anterior and left posterior. Morgagni is a congenital anomaly. Left anterior is the most common. So Morgagni is commonly seen on anteromedial aspect of the diaphragm. So normally diaphragm is anteromedial to the xiphoid deficiencies. So the normal contents of enter through the Larry space or foramen Morgagni. It enters like superior epigastric vessels which are just near to the rectus sheath. They enter into the chest cavity. So the transverse colon from the foramen to herniate into the anterior mediastinum of thorax. So this completes the development of body cavities, diaphragm, along with some congenital anomalies of development of diaphragm. I hope I made this topic easier for you all. Thank you.